And welcome everyone. And I want, I was given kind of this very broad topic, and I guess I kind of have to go sideways because we don't have a screen, do we? So I kind of have to look this way. Sorry if I kind of turn my back every now and then. I didn't memorize my slides. So I was given this broad topic. I mean, why the need for research in healthcare technology? And I could answer it very simply with this, and then I could sit down. Because most of us in this room are probably geeky enough, and this to kind of, this is what drives us. Science is cool, but why in the realm of, telehealth, and why do we kind of sit here and consider forming a potentially new society? Well, there are naysayers out there, and the naysayers are going to say, well, telehealth exists. It's all being done. What do we need more research for? What's the big deal? All we got to do is sell the technology and people will use it and everybody's got their health care. Or it's up to industry now, okay? Let them drive the telehealth agenda. Again, provide the equipment, provide the means, provide the networking and everything else, and leave those academics alone. People are going to say we don't really need research. What we really need is training and education. We just need to train people more. I would argue that half of training and education is research. We have to figure out the best ways to do that. And again, there's people who would say it's up to industry now. There's been a ton of systematic reviews. Menonel and Rashid Bashir, he's done this whole lovely series. Well, it's solved, isn't it? I mean, you can do these systematic reviews. He goes over the evidence. He goes over the cost. They're all positive. What more do we need? Why do we need to keep doing research? And it's up to industry, and I think everybody knows what meeting I'm talking about when I say that. And then there's all those darn siloed academics, and we're not really doing telehealth, we're just researching telehealth, and it really doesn't impact anything at all. So that's kind of the naysayers, but then there's yeasayers, and I don't think that's really a word, but there is a rock group that call themselves the Yeasayers, so I figure I can use it too. And these are just some of my favorite quotes about kind of like why we're all here and what we're doing in terms of research and so on, and especially that bottom one down there, which unfortunately is where a lot of people go for their information. And that is not just your patients, not just your providers. A lot of times it's your CEOs, CFOs, and academics, and so on. And okay, yeah, I've used Google, and there's certain things you can find. But obviously, research is critically important, especially in telehealth. And, we've all seen the pendulum swing, I think. I mean, I think a lot of telemedicine started out as a research adventure. And we tried to figure out how to make it work. Gee, wouldn't this be cool if we could do this, by a tele and so on. Then all of a sudden it became reality. And people did start to use it, and people are using it. And that's why you have the naysayers that say, well, it's just not necessary anymore. It's out there. But there's still so much that we need to look at and so much that we need to investigate, which is why I think we still need to continue to do research. And this is sort of why, from my perspective. All of these things feed into one another. And each one of these is connected. And you can't look at one without looking at the other and the interactions that everything has with each other. Research drives technology. Technology drives research. All of that drives policy. All of that drives need. And you can just look at any one of these connections, and any one of these could end up being an entire research paradigm and a career for someone to figure out where the connections are being made. And every single one of these is dynamic. It's not static, which is why we have to continue to do research and we have to continue to do empirically based studies. Because every time the technology changes, you have to do research to figure out what that impact is. Whether the impact is on the patient, the provider, outcomes, human factors, whatever you want to look at, policy and so on. And you can't just expect something new to happen and not have an impact on all those other features there. And that's what's going to continue to drive research in telehealth, is this spaghetti highway, basically, of what influence is. This is just, I want to talk a little bit about sort of the impact of research. And this is a wonderful study that was done actually on behalf of radiology. But I think it applies to everything, because people, again, will think of academics as sitting in their silos, and it really doesn't have any impact on the real world, and NIH is putting out all this money, and like I said, we don't have to worry about the current political state. But that's the arguments that people are making, that all this money going to all these silly researchers really has no impact whatsoever on healthcare and everything else in the world. And that is absolutely not true. What this study did was look at all of the NIH institutes and looked at the funding of the projects that it had done, and looked at the number of patents that were generated as a function of the amount of funding, and then the mean citations per patent. And it's very difficult to judge the impact of NIH funding on anything, on true outcomes. So we look for surrogates. People look at publications and so on. This is another surrogate for the impact of the research that all of us are doing in healthcare, including telehealth. And from the radiology perspective, it was really cool because NIBIB, which is basically our institute, is way up there with a lot of patents being generated and cited and so on. But every other institute as well, except for, you know, some of these over there, but they're all generating patents too. And what does that mean? Again, technology drives research. Research drives technology. What are patents all about? It's all about technology, intellectual property. And all of that then starts to drive policy in healthcare. And so this, again, is truly showing the impact of research in general. But I think all of these institutes have in the past or are starting to fund telehealth research, and that's what's having an impact as well. So we truly do need research because it is money well spent. And hopefully our Congress people at least will understand this, if not the higher administration. So where's our dilemma in telehealth, and why do we go against those naysayers and say we still need to do research? Here's an example, and this just came out in managed care. It's one of those online type things just yesterday. And it provides, you know, telehealth overview, the reality check, please. And it talks about trends and charts are marching up. Investors are investing, insurers are extending coverage. You know, everybody loves telehealth. And then it says, but there's some skunks at the telehealth garden party. Research suggesting quality and utilization problems and lingering uncertainty about reimbursement. And you can kind of look at this in two ways, and it's exactly what it presents. Is on the top is sort of the researcher's perspective. So you've got Dr. Usher Pines from the RAND, who's done telehealth studies, looked at Teladoc, and found that, you know, there was increased spending on acute respiratory illness by $45 per telehealth user. 88% of the usage was new utilizations, not a replacement for more expensive care. And then you've got sort of the Teladoc chief medical officer kind of giving a rebuttal that, you know, you didn't look at, you know, that they had considerable cost savings, minor increase in utilization. And you've got these two totally different perspectives. And it's like, are you looking at the same data? Who's right? Who's wrong? There is no right and wrong per se. I mean, that's what we need more research about. But so much depends on perhaps biases in the beginning, what you look at, how you look at, and how you define what's good. Is it necessarily bad that there's new utilization? Maybe not. Maybe these are patients that otherwise would not have been utilizing the healthcare system at all. So again, it depends on how you define and frame your questions in your research agenda. And I think that's what part of this society is going to be about, is helping define perhaps some of this framework that we all should be utilizing to address some of these questions, perhaps in a more uniform way. But again, this is just a sort of an example. And there's this duality as well. And we talked about it a little bit this morning in the Matrix meeting. But there's a duality that's facing all of us now, more than ever in the past, I think. Where you've got telehealth, and we're still fighting to get it out there, get people using it. And so we have to keep calling it telehealth. And we have to keep doing studies that call out the fact that we're telehealth. because everybody's saying, well, should we reimburse it? It's telehealth, it's not real health. But on the other hand, we're all saying, but it's just healthcare. Why do we need separate metrics? Can't we just be studying the same things we've been studying in traditional healthcare, the same kinds of outcomes? Why do we have to be developing, inventing whole new ways of looking at healthcare just because there's a tele component? And so we're stuck with this duality. And again, I think that having a society like what we're proposing is going to help us address this duality by getting people together who can hopefully convince people that, this duality doesn't have to exist. We can just study health care in an enterprise fashion, and it doesn't matter how it's delivered. It's the outcomes that matter, not the means to get there all the time. So there's all different types of things we can study, but again, I think it's key that we understand it shouldn't matter whether that tele is in front of it or not. So what are the types of topics that I think are kind of, hot and coming down the road? These are just some of them that I think are going to become more and more important and be some of our challenges. Wearable sensors and all the related issues there. The whole remote monitoring thing I think is super hot and super cool, and people are looking at it to, cure cancer and save lives and everything else. Again, reality expectations, and that's where research is going to come into play, is to help set those expectations as to what we need. Looking at the safety, the reliability and validity of the data that we get from all these things that we're, 24/7 data. Informatics, which hasn't really been a big part of telehealth, is going to be incredibly important. Data mining tools. Avenues for research that are just absolutely open for all of us and taking us potentially in new directions, but again, simply looking at healthcare data and outcomes, and you don't need that tele. Policy, who owns the data? Can research help in that respect as well? We need more long-term studies, really long-term, and really we need these studies. Long-term isn't 6 months. Long-term isn't 8 months. You've got a diabetic who's had diabetes for 20 years and it's still under control. Not under control. That's long-term. And that's where we need more studies. It's hard enough to get that done in the traditional healthcare systems. But we need things like NHANES and that agenda to incorporate, telehealth into that and see how we can get our agenda into some of these broader agendas that look at healthcare in general, but utilizing our methods and our tools. Direct to consumer, huge can of worms. And one day it's good, one day it's bad, one day everybody's happy, one day everybody's attacking us and saying, oh my God, it's no good. I think we need a ton of research in this area, not only on how it's impacting patient outcomes, but the entire patient-physician relationship and how that's actually going to change. Is it going to change for the good or for the bad? I mean, maybe this is the way we want to go. Maybe the new generation wants their health care this way. Maybe they don't care about privacy. Maybe they don't care about relationships with their physicians. Maybe they're okay with the black box stuck in a box that you just call up and swipe your credit card. We got to find that out. It might be absolutely acceptable for 95% of the population, and the other 5% do different methods, okay? But we need the research. We don't know what's out there. And critically important, I think, is absolutely multi-institutional studies. And we need to get the funding agencies to support us in that. But how do we do it? Well, by getting together groups like this and deciding that, what do we have, 12, 15 tables here, that could be 12, 15 institutions. And we could perhaps get together through the Search Society and say, okay, let's submit for a P41, or let's submit for Akron study, perhaps. There's a ton of mechanisms out there. We know a lot about individual institutions. When I review papers, every single paper, I think, a limitation. This is a single institution study. on a limited population. Okay, if we keep saying it enough, it's got to convince us that we need something better, and that something better is multi-institutional trials. And we need to look at diverse populations. We're limited by sample sizes. Some of the things that we're looking for, some of the outcomes, I think, that are published when people say, you know, oh, well, it's equivalent to, or no, we didn't find much. If we had larger sample sizes, I'm convinced that telehealth would win and that we would find much better outcomes. If we did longitudinal studies in multi-institutional, it'd be golden. I think we could do it, and we would demonstrate or prove. I never use the word prove. You're not supposed to do that in science. But I think we could prove that telehealth certainly does have an advantage over what we're doing now. A lot of talk about standardized protocols, standardized controls. And I'm kind of on both sides of this issue. I don't want anybody telling me how I have to do my study. And I don't think anybody wants to do that. But to some extent, I think we do need to agree, perhaps, on a minimum set of requirements on what has to be done, what would constitute a good control group. Is it simply pre and post? Is that good enough? Is it good enough to have, you know, cohort matched? I just reviewed a paper last night on the plane coming up where the control group was those who declined to engage in the telehealth. And the ones in the telehealth were the ones who agreed. Self-selection, and lo and behold, the ones in the telehealth were happier. Well, because they self-selected themselves to be in something that they thought might be pretty darn cool. And then they also had hidden in there that they were appropriate or suitable patients, and never defined what appropriate and suitable meant. So, you know, there's a lot of bias and confounds out there that people just don't think about. And not that, again, we need to create a standard way of doing science that everybody says, okay, I have to do it this way. But again, we need to set some minimum standards or guidelines for how we do research. So if we can't do multi-institutional, we could at least do a meta-analysis that's valid and appropriate because everybody did it sort of in the same way and we all measured using the same tools or at least the same things. So again, search, and we're going to talk about this, you know, for the next day and a half, but the goal really is to support for advancing connected health initiatives and improving connected health care. Again, notice we don't use the word telehealth in there or tele. Create an environment that sustains unbiased and impartial research. It's kind of hard to be impartial when we're all such advocates, but we have to be. Provide education and training in connected health research methods, interpretation, and dissemination. I don't think we do enough of this. ATA certainly doesn't. In the beginning, it did, but in recent years, it really hasn't made this as much of an emphasis. In terms of providing the type of education, not just in research, but in research methods and appropriate ways of doing things in this very unique environment that we call telehealth. And I think that's absolutely critical. So, you know, some of the things that we'd be talking about in this society are providing webinars on how to do telehealth research. What are some of the validated survey tools that are out there? Outcomes tools and so on. So to educate people who want to get into this and encourage young investigators to get into telehealth research. Advance evidence-based connected health naturally, and utilize research in an effective way to inform health policy leadership on connected health research and its implications. Again, most legislatures and so on could really care less about the hardcore data. What works for them are personal stories. But data actually drives things like CMS, societies, professional guidelines that are coming out. So it is important, and we need to understand and promote all of this. And that really is what search is going to be all about. So kind of in conclusion, and I want to leave, you know, like open time for discussion and points that other people want to talk about. this is always just one of my favorite cartoons about research, so I always put it up. Because it talks a little bit about, just creativity, which is what we all have to be about. Talks a little bit about bias. Nothing against the male mind, but come on, guys, face it. How many of you actually did this when you were kids? See, I got some hands here, and I don't see any women raising their hands, so. Sorry. But, it's all about curiosity. It's all about doing research and having a society like Search and developing somewhere where we could really promote things from the ground up and really start to address some of the things that I talked about. Again, that's what kind of the discussions led up to this meeting, and where hopefully we'll be able to go in terms of creating a society really dedicated to research in sort of the telehealth environment. So at this point, I'd like to open it up for comments, question, and discussion for sort of the last 10 minutes here.
We hear from policymakers all the time this conundrum of does policy drive research or does research drive policy? And so if I could urge you as researchers in the field to think about how you move this organization around the 3 pillars of the triple aim. Researchers tend to think so much about health outcomes, improvements in the efficacy of care, which I think is critical. But as we're hearing more and more, this whole question about cost, efficiency, and then patient and provider experience, I think are also key elements. And so that not only to think about how you organize the research, but also how you track it. Because I think that's really going to be the real impact of an organization like this. The other point I'll make is the precision of language. It's really been frustrating for me as a head of a policy center on a national level to respond to all of these inquiries from the headlines that say telehealth doesn't reduce costs. From one study that was based on a supplemental benefit in the health plan for a direct-to-consumer benefit. A very narrow perspective of telehealth, but with one broad sweep, the headlines that we see across the country, and then you just reference here, that think that's all about telehealth. So I think to the extent that, as you say, it's healthcare that's driven by the modality of connected care. So specifically, what form of healthcare, what form of telehealth care, so that when we talk about it, we talk about it with real precision. So that's what I would encourage you as a society as we get this off the ground, to not just think about improving health outcomes and the efficacy of care and getting the patents and all that thing getting published, but also from a policy perspective that we need to focus on those 3 areas. Thanks.
No, absolutely, I agree.
Thank you, Judd Hollander from Jefferson. I come at this from a little bit unique perspective, but I'll stop and point out that the 2 of the authors of that article are in this room. And I say that because that's what we need in this room. So Laurie's sitting over there and Ativa's over there. And I think that's how we solve our bias problem. We solve our bias problem from people who challenge our assumptions. And my perspective, I'm an ER doc. I've been a career clinical researcher. I'm now the administrator for an enterprise-wide telehealth program. And then I do something really neat. I actually do telehealth. So I actually see, whether or not I can do what I could do on that. And when I look at the research background, one of the things we're doing now is we're pulling off little slivers. That's all we can do right now because we don't have really robust databases. We can't answer the question the perfect way. The data that came out that they published is the data they got. That's the best you could do using that database. It may not be the best way to do it. The best way to do it may be to get prospective data together and look at this and figure it out and have health systems share their data or payers share their data in a more robust manner. But we can't do that. We're stuck with a dilemma that the field is moving ahead faster than we could get the data. The CBO wants to make decisions. We're getting pressure to do that. I walked around the posters and looked at one thing on every poster, which was the N, the number of people studied on the posters. There might have been 2 that hit 100. The CBO is not going to make their decision based on 100 or 200 or 300 patients. So we need to really partner and work together to do this. The other thing that I think we need to do is we need to stop talking about telehealth and not telehealth. So where we've been successful in grant funding, and it's through 3 different agencies and, pretty decent sums of money, is where we've done something that added or enhanced normal care with telehealth. And the question, can you treat disease X more efficiently by removing some visits and replacing some of them with telehealth, has been fundable in basically every grant we've submitted. And so if you try and do, is telehealth better than regular care? It's a bias. Regular care is going to be assumed to be better. You're not going to show it to be better, probably. So I think we need to think more creatively. And, I think my impulsive thoughts are the same as yours and everybody else in the room when Laurie and Atif and others published that paper. But they're trying to do something and answer a question in a manner that I think we need to embrace and work with them and keep them around as we're going forward saying telehealth is great, because we need to temper our enthusiasm, and then we need to temper their lack of enthusiasm and come out with hopefully the right data at the end of the day. But I think this organization is the organization that needs to move that forward.
No, absolutely, and I, having and it's that balance between questioning and answering that we need. I mean, every data set has its limitations and every data set has its benefits. I think, both of you brought up some really excellent points. And, there's so many of us that have been arguing for years to get rid of that tele part. At Emory now we call it virtual patient care. I'm not sure if that's any different. Somebody once asked me, well, are the patients virtual? Like, do they have avatars? And it's like, no, it's not just a simulation. So no matter what we call it, there's some confusion. It puts it here where it shouldn't be. It has to be part of the system, part of the enterprise. It's not something outside and different. And that you're right. We can't study it that way either. We just have to study it and present it as if it's the same thing we're doing, just with different tools. So again, yeah.
I'd also like to make a plug. My name is John Hsu from Children's Hospital of Philadelphia. I'd like to make a plug for the art of the implementation science. And I think this is a great opportunity for us to not only look at efficacy of an intervention, but the effectiveness of an intervention. So this is a great opportunity for us to incorporate implementation science and do it as an implementation science in some of these research projects.
Mm-hmm. No, absolutely. And we were talking this morning about, how a lot of times, up to now, people are still looking at patient satisfaction. Did you like it? Could you see the provider? Could you hear it? And I basically said, that's all well and fine, but let's extend it just a little bit further and ask the patient, did you learn anything today through this encounter that is potentially going to affect the way you take care of yourself? Well, and gosh, we could ask that of patients in person and tele, and it doesn't really matter, but that's the true thing that we're after, isn't it? That the encounter somehow impacted the patient, not whether they enjoyed it. Who cares? None of us enjoy going to our doctor's appointments. That's not the point. The point is, did we get something out of it? Yes, I got a prescription, okay. But did you learn something that's going to help you prevent something like this in the future? And it doesn't matter what the technology is behind that.
Very well from the get-go, that get studied, and because they're designed poorly, their results are always going to be poor, and they seem to get more press than anything else.
That's the unfortunate side, and that's why we need to put out all the good science. And to some extent, like I said, that's where we need the multi-institutional. We need to attack with numbers. To some extent, it's, Napoleon in battlefields and going back to that mentality almost. How do you win a battle? It's with numbers and with good strategy and by having good friends rather than enemies. And that's what we can do here.
One problem is a lot of stuff gets published, but there's not enough good stuff, right?
Yeah.
In lot of the journal articles, it's tough to get especially when the Swedish countries are now publishing articles with, 10,000, 20,000 patients, so it's hard to get in the U.S. journals, but it's because good work trumps bad work. And in a lot of our stuff, we see a lot of crap published because, they got to put something in the journal, and so that's fundamentally the problem, I think, with a lot of it.
And there seems to be this pervasive negativity. I mean, there was a few weeks ago, they released a study on Repatha, the new cholesterol drug, and 20% decrease in the bad cholesterol. I mean, huge. I mean, my husband's on it. It's amazing. And yet there was, well, that's not enough. My God, 20% decrease, that's not enough. And this is not worth it, It's like, what? So there's this pervasive attitude. And yeah, to attack it, you got to come out with a gangbuster force of a lot of people saying, sorry, you're wrong and we're right.
The opportunity for us to set the metrics that are
Exactly.
clinically relevant. I mean, when you're doing a study, as clinicians, you say, what's a relevant change in it? And then that's how you do your power calculations. So I think opportunity for us to have some input to some of how these things are designed and what you're trying to do. And we do look too narrow in this thing. We're talking about, a system of care, systems of care, not like we're doing it today, which is siloed kind of care. And it's going to, when you squeeze Play-Doh in your hands, it oozes out from between your fingers in many different places. If you don't study the whole process, you wouldn't see that. You'd just see one of the oozes out. So, and that's some of the problems with these approaches. You have to look at the sort of the whole system and the changes we're inducing.
Yeah. Although I don't want to see any power analyses from the majority of studies that have been done in telehealth.
Yeah.
Let's not go there.
So, another question that I think we do wrong, and in a relatively vendor-free zone, one of the things that we do need to do is when we at our institution sign our vendor contracts, we have to mandate that we could get the information. In my research career, I could tell you, hundreds of research proposals. My institution has never let a contract go out the door that doesn't give us the rights to publication. I can tell you that many of the vendors, and some of you know different vendors or more than me, don't give you the rights to publish your own data. And if we banded together and refused to sign a contract that didn't give us the rights to publish our own data, they couldn't sell their product. If we banded together and decided what are the core data elements, I'll take direct-to-consumer, that every direct-to-consumer platform has in it that people could get feedback on, and we didn't buy a product that didn't give us back that data, they would all give us the data that we could get together. And several of us in this room are on National Quality Forum Committee that's looking at developing a measure framework, and the goal is to have e-measures. There's nothing more ridiculous than not being able to get an e-measure from a telehealth vendor because the information's not in there. So I think a big plea at the end of the day is we need to decide what information do we need from our vendors, we need to work with our business partners at our institution, and we need to not buy the best thing out there that still sucks. We need to make them create something good enough.
Yeah.
Yeah, thanks, Judd. And Judd, in Philadelphia, they're hosting the search meeting in the fall. When is it, Judd? October 5th and 6th. And so we'll provide some information, and so as many people can attend Judd's meeting and stay for the search. It'll be something like this. The concept is to pick up more and more people from around the nation to be part of this. And, as you get local people engaged, then maybe they'll, continue to be in the bigger group as it grows over time. But I think there's a lot of people very interested in trying to do something like this as a new venue for, more really the kind of questions that we need to be asking. Thanks a lot, Liz.
Oh,
that was a
thank
great
you.
presentation.
Thank you.
So.